Professor Hosvang. Welcome again. After your excellent talk on the previous panel and the field that the buzzwords artificial intelligence combined with continuous monitoring may be the leap forward that healthcare needs to improve patient outcome. We are ready to hear about your work and personal views.
Thank you, and thank you for allowing me to continue. It is a quite big field, and artificial monitoring holds some promise. And I'm saying this way because it also needs to be addressed the right way to begin with. So again, this is actually the funding, etc. I've added this because I will be mentioning the products from the Isansys, which is in the booth down there. And I've been working with this group very early on. We haven't got any funding from them, just a lot of lovely support. And basically, it's all been about deciding the right monitors to collect the data, because there are a lot of monitors, but I have to say this was lovely to work with, and is actually. So AI in healthcare, we have it in lots of various specialties. We all know about mammography, and actually it's the imaging specialties that has moved it the further away. I'm sorry, I have a bit of hard time concentrating. Sorry, thank you. What we also have is actually closest to what I'm talking about today is glucose monitoring and smartwatches. And you know these from your patients. They come in with these devices. The problem is also, how do we then deal with this, the information the patients are giving us? So the real challenges, which I'm going to be talking about today, is actually the data amount, especially the quality. How well is the data we're trying to design our AIs on? How well can we train them if we don't put the proper data in? And this is especially important about the outcomes. You cannot just use coding from journals as big, like data mining, because doctors are not very good at coding for complications. We can see this in various studies we've done, so we need to do this manually. We also need to make sure that the data we use on the specific patient, the AI is then used for, actually came from patients like that patient. Otherwise, we're introducing bias. And we know this throughout medicine. Beta blockers for African Americans doesn't work equally well, actually sometimes very poorly. This is exactly the same for AI, it's basically the same problems. And how does simple models work in a very complex environment, such as a hospital, with lots of different interactions, lots of different things happening, compared to a very simple model in a computer system? And finally, do humans actually trust machines to tell them what to do or guide them? Well, we do in aeroplanes, I think. We do it other places also, but this will take time to get us adjusted to. So what is AI actually? Well, it's everything from linear regression equations, basically. And this is actually, I think, where lots of these studies are right now, and where we have experience-based models, where you try to mimic what experienced physicians do, because they think they know best. It's called eminence-based medicine, not evidence, but eminence-based medicine. Then we should move into the field where we have data-driven AI, where we actually can challenge the normal things we do and say, is it really true? Or is it supported by the data later on? Can we actually find the same patterns? And if not, try to understand why and then design it after that. And in the end, we of course would like to have two chaps like these who are self-learning, who can see what happened and then start to build their own system and logic. I showed this just before, I'll skip to this. But again, this is so important to remember that we need to monitor to be able to rescue in the end. I'll also just skip this one because I think I proved this last time that the data supports that continuous monitoring do find lots of patients who need to be attended to, but also some patients who really don't need to be attended to. But the problem is we still need to look at some patients who don't need us to find those who do. And coming back to this one, I didn't know we had the same room actually, I thought it was two rooms. So I'm just skipping these, and I'm going to pay lots more attention to this actually. So this is actually rubbish again, sorry, I thought I promised. So this is the problem here. We've already solved intermittent versus continuous. This is done. This is something we can do today. This won't be a problem for us anymore. We've also managed to look at places outside the ICU or the OR. I think one of the problems is that if it comes very low-key, is about too many devices. We need something that is integrated. For instance, the ECG patch we're using both has ECG, respiratory rate assessment, positioning, and activity, which is lovely actually. But why couldn't it also have blood pressure measurement and plethysmography, saturation devices? We all also only have one telephone in our pockets right now. We need something more. Sorry? Oh. And the reason for me saying this is very, very, very low practical. If you have a patient who actually wears a blood cuff device on his arm, that patient might not be able to dress himself in the morning. And then the nurses have to come to the room anyway and help them. I know this is not very technical. This is just so non-AI. But this is something that prohibits these systems from being introduced. And of course, we need to reduce these alert fatigues. And we also need to make sure that our alerts are quite specific, because once we find something, we have a tendency to do something about it. And nowadays, we know even oxygen supplementation is actually dangerous for some patients. And we will risk over-treating patients who don't need it. And this is based on tradition and conservatism. We know that people have been using the same thresholds for hundreds of years. They don't want to give it up because it's not that easy to do, because it takes energy to do. And we need these feedback loop system, which is basically drawn over here. So this is our system right now. And I have to come back to this group down here. This is so important that when we design AIs, we design them in collaboration with the end users, the nurses, also the patients, because we have the risk of introducing anxiety. But actually, I would say right now, the problem is introducing too much comfortness, because patients actually think that once we've just put a device on them, they're safe. We told them in the beginning that we're not going to do anything about it. We're just going to monitor you, collect the data, and do nothing. I feel so safe, they said. I feel so safe. We said, no, we're not going to do anything about it. Do you hear me? Oh, I'm sorry. I'm not very good friends with this one. So, try this one. Yeah, even better. So this is the broad project. I'm just going to show you how far we've gone. But actually, as you suggested, why did we choose those patients? So we actually made this project as a classic scientific project with pilot studies, observational studies, and then a lot of sub-studies in different populations. During the COVID crisis, we were asked to actually come out and help in the departments with this system. First of all, because it's actually means the nurses don't have to touch the patients, they can do it remotely. And it, of course, reduces the infection rate. But I'm pointing this out because this study here actually brought something to our attention. We were thinking that we were building an alert system. We were actually building a system that made the nurses and patients also, but also doctors, more safe about the patient's condition, allowing them to do things away from the patient. So you think you're building an alert system, but basically what they want is knowledge that this patient is doing fine. You can address your attention to something different. I think it's the same in the OR, where we have a saturation monitor that tells us by sound the saturation is fine. We know this all the time. It just bleeps with a high pitch volume. Everything is fine. I can draw my attention to other problems the patient might have. If I didn't have that, I would have to look at the patient's color, skin tone, whatever have we, all the time. So this actually introduces the ability to do something away from the patient. We've moved into the home now, and we just finalized RCT here. And I'm very happy with these two phases, where we're now trying to do proper at-home studies, monitoring from home, and seeing how we should build such a system. And now we have to move into the world the next year, and I'm going to look so much forward to this. So, to begin with, we tried to see, could we actually build a system that would reduce the alerts? And what we're doing here is taking the traditional way of having alert thresholds and an alarm, having actually the first version in our project was having like a feedback loops, or when should an alert be sent, what was the different other devices telling us about the patient's condition. And I'm sorry, there's something really gone wrong with this slide also. Data from our PACU, and actually what we showed here were, by using AI, we were able to predict PACU alerts 10 to 12 minutes before they actually occurred, with a quite nice sensitivity and specificity. So this was one of our really first projects, and this told us we're on the right track. See, what we then did lately is we took around 1,000 patients, and we looked into when do the clinicians start suspecting something is wrong. And this was timed 0. And then we looked in when do the alerts start detecting something is wrong. And it's really amazing. It's almost 43 hours before the clinicians we find something is wrong. The clinicians only suspect something is wrong 30 minutes before a serious adverse events occur. And this should actually give us a lot of time to start intervening. See, of course, the problem is that we have a quite low specificity because we detect too many patients who we don't need to do something for. But right now we have a so-called number needed to observe. It's something I termed, which is 2.5. So we need to observe 2.5 patients to be able to help one patient actually. I think that is okay. And this is in preparation. So another problem is the alert fatigue. How can we reduce the majority of the alerts here? So we took again the patient population. And what we can see is if we have a system without artifact removal, then the artifact removal removes around 20% of all alerts. If you have artifact removal and AI as we've built, we are down to around 86% reduction of alert intensities. This just shows us we're on the way to having a quite substantial reduction of alerts. We're down to around 12 alerts per patient per day right now, as compared to around 190 per day. So I think it shows the way that AI can help us here. It also shows us that the patients with complications have more alerts than the patients without. So the balance is tipping the right way. We will have more alerts in those who need us than those who don't. Again, coming back to what I said before, is about reintroducing physiology. This is the perfusion index, and we all know this. This is the difference between the pulsatile and the laminar blood flow in the finger. And the more stressed you are, the more your blood vessels contract peripherally to pull the blood centrally. It also happens during stress, pain, anxiety, etc. We've shown that a perfusion index around above 15, and of these have a very low mortality risk. But the smaller your perfusion index is, the higher your risk of mortality increases. And maybe in the future, we should start looking into using something like this instead of blood pressure, because we all know low blood pressure can be acceptable for some patients, whereas another cutoff thresholds of blood pressure could be dangerous to some. For instance, 75 middle arterial blood pressure. So we know now that PI, low perfusion index, precedes mortality, and we know it has a higher correlation to clinical outcomes than blood pressure actually does. But how do we change 100 years of clinical practice? This is difficult, and it needs a really, really substantial input. Another thing we need to introduce using artificial intelligence is trying to implement the circadian rhythm all humans and living things on this planet has. Trees have it, any animal has it, we also have it. It means that during the day our body reacts differently, different hormone levels, etc. And this is heart rate during the day. So during the awake hours, you have quite high heart rate, and during the night, it's quite low, actually. And you can look at it differently, the difference between day and night, nighttime nadir, etc. You have the trend, etc., and so on and so on. One of our PhD looked at this recently. This line shows you no difference on the different modalities. What it shows here is actually, if you look at patients' heart rate, those patients who don't have a drop in the heart rate during the night or respiration rate during the night have a quite substantial risk of a complication being detected the next day. And I think we all know this. The patient who has tachycardia, relative tachycardia in this case, and not just very severe like 130, but quite doesn't have the drop at night as they should have. Those patients are stressed. And why are you stressed after surgery? Well, you could be anxious, but the majority of cases is because you have an oncoming complication we just haven't detected yet. So this shows us we have something to do here also. Oh, just going here. So, yeah. So the patients who actually look normal at night are in this study actually the patients who have a problem, because they look normal compared to daytime alert thresholds, which you shouldn't have at night. You should have different thresholds. Another thing is maybe we should start looking into other totally different vital signs. Blood glucose. Well, we all know that having a normal blood glucose is good for you. Yes, it is. But is it because the blood sugar itself is dangerous? Maybe not. Maybe it's because the blood sugar itself is a surrogate for an oncoming complication also, because your stress hormone levels rises and then your blood sugar rises also. So maybe that could be an input that tells us something's on the way here. This is a pilot study, and we're hoping to continue it next year. We took a population of diabetic patients. We didn't get that many because this was during COVID, and all the real diabetes patients stayed at home, luckily. We monitored them for 10 days. We monitored hyperglycemia episodes, and this was with continuous monitoring devices. We found lots of episodes of hyperglycemia detecting in this way, and these are, of course, dangerous. These should be cared for. We also found a very poor time in range of all patients on insulin, these diabetes 2 and insulin and diabetes 1. And a very significantly increased complication rate in patients with hyperglycemia, with a very small patient group actually. So again, telling us that maybe we should look into this actually. And maybe hyperglycemia predicts oncoming complications and is actually an early warning sign. So this one is really interesting, I think, especially for anesthetists. We took our cohorts of patients and we monitored them with our saturation monitors 1 hour before they got opioid. We could see in the data sets, and compared them to a group who didn't get opioids. Same group, same surgery, etc., etc. We monitored them 24/7. What we saw here is actually, this is the opioid doses, and these are the minutes with severe deviations of saturation or respiration rate. And normally you would have like a line going this way, or cluster of the dots going this way. So it tells us that some patients react quite severely to small doses, whereas other patients react very little to quite high doses. But it's really hard to predict which one is which. And we can also see, these are hours out here. This is 4 hours after morphine administration. We have a continuous dip in saturation in the morphine group, which we don't have the control group. They just keep continuing declining. And normally we say to the PACU, I do at least, well, let them stay for half an hour if it's a tablet, 15 minutes if it's IV, because then we know they're stable. It doesn't look that way, because when people fall asleep, something different happens. In the PACU, they're awake, and we send them up to the ward where nobody cares for them. They care for them, but they don't have enough hands to be there. Sorry, well, I didn't mean that in any way. And it's also about analgesic tolerance develops very fast. We know this. Well, we know that respiration depression tolerance develops very slow, or maybe not at all. We all know drug addicts have a very good tolerance, but even them actually do tend to have an increased risk of complications, because what do? We just give them a higher dose when we give them something. When you do that, you don't have the same adjustment graph as these guys do. So again, using AI and continuous monitoring might help us identify those patients where we should pay a bit more attention than we do today. Finally, I'd like to say that what we need is to use these data to build so-called patient-like-me information, so we can have a proper discussion with that patient. How is this surgery going to go for you? What risk factors do you have that we can find in our database, so we can look at you and say, okay, is it really worthwhile being operated for something that might not need surgery? Or is it really worth being operated for a cancer and you have a risk of staying in hospital the rest of your life in agony with problems, etc.? Maybe you shouldn't opt for surgery. Maybe we shouldn't do it. This is a big discussion in our country where we have too many treatment options and too little resources actually. And sometimes I don't think it's about resources, it's about we're giving some patients a poor outcome than they would have without surgery. And we need to help our surgical colleagues to define these data. So basically this is what you want. You want to take all the data here, use analytics, and then have this personalized risk score, and then have a discussion with the patient. And sometimes you would just say, well, I'm not going to anesthetize you because it won't go very well for you. So find somebody else if you will, but not me. So coming back to what we actually built, this is our current system. We have all these different, I think you all recognize these, all these different parameters, which is a very basic parameters for alerts. This is our first version, which is up and running now. It's working beautifully, and I'm really looking forward to be able to present our outcome data. I hope it will show something. I don't know, because basically the problem is we can do all these things very elegantly and very good, but if the clinicians don't do the right thing to the patient afterwards, well, then we have to reconsider, and then we have to redesign it and do it again, and then do it again, and then do it again. But at least we know what to do then, because right now we might be doing things that doesn't work. So the next generation we're looking at right now is actually implementing the circadian adjusted thresholds, but also activity, because a patient moving around might be okay to have an increased pulse, especially if they're anemic. But once they lie down, they shouldn't have a tachycardia. And we should also be able to root out those patients who are actually lying still, then have tachycardia. Because if we do this, we might have a bigger chance of having more sophisticated and sensitive alerts actually. Trend analysis, everybody's talking about this. We need to make sure it works. It means it's individualized. Instead of just have a threshold, you have, for instance, an increase or decrease in the opioids, individualized. We can already use ST signals to see if we can find some sort of ST deviations that are related to cardiac complication, and the perfusion index, of course. So again, the conclusion is basically the same as I said before here. But I think when we come down to this part here, we need to make sure that the alerts are adaptive, that future alert systems are individualized. Again, the issue here is how do the staff then react to this? How do you inform the staff of what to do with individualized alerts? It's a big task we have ahead of us. And of course, context sensitive. I do think that the future is here. So combining wireless continuous monitoring and AI is really the optimal setting for us to find those patients who need us and to improve their outcomes. And thank you so much for listening to me, and sorry for the technical mix-up.
Thank you for your exciting talk. I have a couple of questions. I work as an anesthesiologist at the Centro Hospitalar Universitário São João, Department of Anesthesiology, mainly in the field of ambulatory surgery. We treat there a wide range of patients regarding age and comorbidities. Typical examples are old patients suffering breast surgery with reconstruction, with cardiac problems, hypertension, and diabetes. When looking for ways to make ambulatory surgery safer, we are planning to use telemonitoring at home in the early post-operative period. In fact, we developed a feasibility pilot study with telemonitoring 21 patients that proved to be well accepted by patients and ensured reliable results. We recently purchased all of the equipment, and my questions are, how can we put this kind of technology to good use in the setting? In ambulatory surgery. Do you have any hints about the patients who can benefit more? And how to couple in the clinical settings all the flow of data in real time with artificial intelligence in order to get meaningful and useful data?
Yeah, thank you. So let's start from the way back. So right now, this system we've been building is actually in real-time data. So we get the vital signs data from the devices. You can see some of them down there, sent by real-time to a central computer that analyzes and give the nurses the feedback instantly. Actually, we have a criteria. I think it's about half a second delay we accept, because we need the data to be on time actually. Because you don't need to be told, well, we could tell you that your patient died yesterday. Well, thank you. I didn't need that. I would like to know what happens right now, actually. So I think that is technically feasible. We've shown this, and of course, but it demands something of the institutions, Wi-Fi-wise, etc., etc. Your other question, was that about how do you implement it? Was that the thing?
No. We wait for the implementation a month ago, more or less. We are the equipment and we need to implementation. And I ask for the patients who benefit with this.
Yeah, well, I think we had the discussion early on that you would of course start with the patients who are highest at risk.
Okay.
And
Yes. Breast surgery with reconstruction. Surgery about 3-4 hours.
Well, we've said more than 2 hours because that is actually there is no international defined agreement on major surgery. So I think that we all know our own patients. So you would, of course, ask your nurses which patients are you most often seeing problems in. And that can be either thoracotomies, it can be laparotomies with near diaphragm incisions. It could also be high-dose opioid treatments. So it's very different from place to place. Okay. And I think that each center needs to find those, based on their own data, who has the highest. And then you find out, okay, maybe we're giving too much opioids. Maybe we should reduce it. Then you have another population get the devices. So you adapt all the time. What we actually did here, we took populations who were already enhanced recovery. We had tried to optimize it because I don't think you should introduce very advanced systems if you can have the same improvement by doing something very simple, having checklists, reducing your opioid use by having multimodal anesthesia. Maybe you don't need this. And then you can reserve it for those patients who really need it because they don't get better anyway.
Okay, it's the same equipment but different patients.
Yeah.
Okay. In Hospital São João, now we have a patient monitoring. Can you, a plateia quer ver algum doente monitorizado com este sistema atualmente, neste momento? Se quiserem, pode-se passar o vídeo e o doente responde. Não sei se tem interesse ou não.
Sorry, I didn't.
At this moment in Hospital São João, we have a patient under telemonitoring. We can connect to her. Do you want?
Yeah.
Yeah?
I don't know what kind of system it is. You're welcome.
We can talk
Yeah,
to the
sure,
patient.
yeah.
Well, I've been chatting all afternoon. There's one question I would like to make. You're eagerly waiting for the results that you will be presenting. But I have a question that most of the items you presented that you are including apparently are being used by the technological companies in wearables. And actually, they seem to be becoming more and more reliable. Do you see the future as being able to use these wearables, especially for the remote home patients, to be integrated into a system like this?
Yes, first of all, I think that we need, sorry Keith, we need to have a discussion with the device producers about open API. We need to have a discussion about sharing knowledge so we can choose the best devices, because my hospital, for instance, makes agreement with Philips, and then they're stuck with Philips for 20 years, and we cannot get the data ourselves. Philips owns also the data, which we nowadays know is totally rubbish, because why should we give them the data? It's the patient's data, actually. I think that devices will become better and better. They are actually, and devices can be used from home right now. It can be used either in the very advanced way we're doing it with continuous monitoring second by second, or you could use it as in normal telemedicine where you have the patient monitoring and then typing in. I think both things should be used. One thing is from the acute phase, that is what we do. And then you have in the longer phase in chronic heart failure patients, for instance. Yeah, so I think that I like patients to be at home. I don't like them to be in the hospital. Yes, definitely, I agree with you.
Já estamos ligados com a doente que está monitorizada no Hospital de São João. Se quiserem fazer perguntas à doente, nomeadamente se é confortável, se incomoda alguma coisa na vida. Esta foi uma doente que foi operada e não pode ir para casa pelo motivo cirúrgico. Agora, ela está ali e poderá responder se é um equipamento que, se ela fosse para casa, ia incomodar na sua vida. Não vou dizer o seu nome, desculpe, mas diga-me só uma coisa, tem alguma coisa no seu corpo, puseram-lhe alguns adesivos ou assim?
Sim, colocaram dois.
Sim. Sim. E tem algum aparelho também no dedo, a medir tensões e assim. E desde que está com isso colocado, teve limitou em alguma coisa que pudesse fazer? Nada. Se fosse para casa hoje, com isso, acha que conseguia fazer a sua vida normal? Muito bem. E teve alguma dúvida? Não teve dúvida nenhuma. Não sei agora se querem passar um traçado. It's a patient in Hospital São João. Professor Esca.
Hello. Nice to meet you. I hope you get better soon. Are you being monitored with anything?
Can you, pode mostrar, por exemplo, o que tem no dedo, o braçal das tensões?
Okay, yeah. Okay, how does it... Okay, yeah. Well, it's the same thing we're using, so very good, yeah. How does it make you feel?
Como é que se sente com isso?
Sinto-me bem.
It's well.
Okay.
Sem qualquer limitação.
Yeah.
Without limitation.
Yeah, and what are you admitted for? Sorry, we are room full of doctors here. Is it okay to share? Is it okay to ask you what you're admitted for?
Consegue andar aí um bocadinho? Anda um bocadinho aí assim, leva o telefone consigo para vermos, está bem?
What is her disease?
Sem qualquer problema. Também já fui ali ao computador, dar uma voltinha.
It's work in the hospital?
Yeah, but what is her disease? What is she admitted for?
It's gastrectomy.
Hysterectomy. Okay. Okay. So you're trying it out. Is it just to try it out? Because normally you shouldn't have.
It's for the conference.
Okay.
We asked the patient to monitor. Thank you.
Thank you. Thank you
Obrigada.
so much. Thank you.
Muito obrigada. Adeus. As melhoras.
Thank you.
And thank you for...